Dr. Meher to start.
Perhaps he has some network issues. So let me welcome all of you for this program. So now we are running the 6th series of ophthalmic resident under the banner of EIZOC. So we have with us Dr. R.C. Meher, the president of EIZOC. Somehow his network is poor, so he's not able to join now. We have our vice president, Dr. sir, with us today. We are very happy to welcome you, sir. Dr. Rumta sir is there. He is the organizing secretary of the coming 35th EIZOC conference. So we are happy and we welcome you to this program, sir. Now coming to the program proper, we are also very happy to have Dr. Vinita Rao Pathak with us, because it is always a pleasure to listen to her. The commitment and the interest with which she explains the details about glaucoma, I think all our residents are very lucky to have her in this program. So I expect all the residents to interact with her and to clear their doubts, so that it will be immensely beneficial for them, not only for the exam, but for their future glaucoma practice as well. So with this brief introduction, now I request our Chief Coordinator, Professor B.N.R. Subudhi sir, to start the program.
Thank you, Dr. Patnaik. Let me
share the screen. Good evening, sir. I'm having some trouble with the connection.
Let me share the screen. So my screen is visible?
Yes, sir. Yes, sir.
Am I audible?
Yes, sir.
Okay. So, good evening, respected President Dr. R.C. Meher, Vice President Dr. Pranav Ranjan, and Chief Organizing Secretary of EIZOC Conference Dr. S.K. Rumta, and my friend Dr. Patnaik, above all, today's our mentor Dr. Ajit Babu, and today's speaker Dr. Vanita Pathak Rai, and all the participants of this webinar. I welcome you all on behalf of the EIZOC to our series number 6. This EIZOC Ophthalmology Residence Teaching Series number 6. And till now we have completed the UVI series. Now we are going to the glaucoma series. And today's topic being the optic disc evolution in glaucoma by none other than our famous speaker, Dr. Vanita Pathak Rai. So as you know, this series of ophthalmic resident teaching series is meant for the postgraduate students, and today I will be really happy that there are more than 16 postgraduate students have joined today on board online, and also many more will be hearing behind the screen. So there will be very good interaction with the postgraduate students today. They are our office bearers of EIZOC. And today's speaker, she is well known to us in not only in our state, because she has already spoken once in our webinars, and she's very famous all over the country. And she's to say briefly about her. As you know, today's speaker is Dr. Vanita Pathak Rai. She is presently the Director of Glaucoma and of course Senior and Glaucoma Contact Specialist at the Center site, Hyderabad. She has had glaucoma fellowship at the University of Toronto in 2004, and mostly her areas of interest are minimally invasive glaucoma surgery, MIGS, innovative surgery, PSCG, plateau iris syndrome, refractory glaucomas, combined cataract and glaucoma surgery, and tubes. The plethora of all glaucoma surgical group. And her major achievements are first Indian glaucoma specialist to perform microtrabecular bypass MIGS I-stent, first to perform MIGS in endoclosure glaucoma, that's called PECO endocytoplasty, and first to use Rahuk dual blade to perform trabeculectomy in adults. She has over 70 publications in journals. She is very passionate about teaching and training, and she has presented as invited faculty in various national and international meetings. She is also the reviewer for several prestigious national and international journals. to some of the awards. One of the most important award I will enumerate here, that is, she is the international hero 3 times in a row by All India Ophthalmology Society annual conferences 2017, 2018, 2019, and some of her winning, prize presentations are, but the most important prize winning presentation being the Southwest Ophthalmology Society at UK 2003, the topic being blind in 2005, social deprivation and unmet needs. And she has more number of awards and felicitations, but I don't want to enumerate them. So to these brief words, I welcome you, madam, to today's webinar. Today's moderator, everybody knows Dr. Pranab is very famous in Eastern sector and also all over the India. She is stationed at Patna. And today's panelist being Dr. Sarmishta Behra from Burla, Dr. Richa Gupta. Everybody knows her. She is very famous in her subject. She is in Sunitra at Delhi. And of course, Dr. S.K. Ramta already have told that he is the based at Bihar, Ara Bihar, and he is one of the prolific speaker and also best organizer, I would say. He is organizing, this annual EIZOC conference starting from 15th of this month. Dr. Sangeeta Basantra, she is a glaucoma specialist trained at LVPI and stationed at Bhubaneswar. And of course, we got a plethora of postgraduate students. There are more than 16 postgraduate students from different institutes of our country, and notably being because we got a number of students from Warangal, KMC Warangal, along with them Dr. Viva Singh from BHU Banaras, Dr. Pradyumna Mishra Bimsa from Burla, Dr. Ankita Sharma from AIMS Patna, Dr. Pratibha Behra from MTC Medical College, Berhampur, and Dr. Amit Vidasya from JP Rotary Hospital, Cuttack. So these are all the postgraduate students, and besides them, so many postgraduate students. They are behind the screen. Probably they will be interacting with madam. Madam, you can categorically ask questions to these people so that they will be very much remain in the active in this program webinar. So these few words, I welcome you all to this webinar. Now it's over to Dr. Ajit Babu to say a few words before the speaker takes over. Thank you. Thank you all.
Let us not waste much time. The series on glaucoma has started now, and we will be followed by another 15 to 20 lectures in glaucoma. So the whole series will be by eminent speakers, alternate week in ORTS, and the research wing is again simultaneously going. So next 2 weeks, again, we will go for another topic, but please, all of you should pay good interest and learn the best that is possible. And Vanita is known, very well known speaker, and last time she did very well in glaucoma. So I expect her to give a decent lecture and a excellent interaction with the postgraduates. Vanita, it's over to you. You're muted. You are muted.
Dr. Would you like to say a few words?
Yeah, just a few words on behalf of EIZOC, sir. Thank you so much, Dr. Ajit Babu Manji, for giving your valuable time and conceptualizing this kind of a webinar. And I welcome Dr. Vanita Pathak Roy also to the EIZOC platform from the EIZOC family. And just a few words about disc evaluation, which is the topic of discussion today. What I feel is that every glaucoma patient will have a disc change. So disc becomes a very important factor, and everyone who is practicing glaucoma, not only the glaucoma people, but also an ophthalmologist, he should understand and should know very well as to how the disc behaves in glaucoma patients. So it becomes very important. And with these few words, it's over to you, Dr. Vanita Pathak Roy.
Thank you very much. Indeed, Dr. Ajit Babu, Dr. Pranab Ranjan, Dr. Subudhi, and all team members and everyone under the auspices of EIZOC. Thank you for this invitation. I definitely am very pleased to come back and give this lecture on how to examine. I mean, I don't just call it evaluation, I call it examination, because I give you tips, practical tips as to how you can actually, on the slit lamp, optimize your viewing of the disc to be able to diagnose glaucomatous changes. I have to say, I have not included neuro-ophthalmological discs. That is a completely different topic, as well as takes up a lot of time. So I limit myself to glaucoma here. And just for everyone to be on the same page as to what we mean by glaucoma. Glaucoma is not one disease. It is hundreds of diseases. It's a heterogeneous group of disorders, which is chronically progressive and causes an optic neuropathy, in which you get characteristic morphological changes not only in the optic nerve head, but also in the nerve fiber layer. And this happens due to progressive retinal ganglion cell death. So the actual seat of damage is the RGC layer, is not the RNFL. RNFL is just the axons of the ganglion cells. And these axons join up to form the optic nerve head. So the changes occur in can be seen in the optic nerve head and the nerve fiber layer. In my opinion, you can see changes in the nerve fiber layer much before you can see changes in the nerve head. And that is why I would like you to tune your eyes, train your eyes to look at the nerve fiber layer in much greater details than is ever taught. Where visual field changes are concerned, they are very characteristic, but may require up to 40% damage before it manifests. Where is IOP in all this? It is only a risk factor. So since the 1980s, 1990s, intraocular pressure is no longer in the definition of glaucoma. Please remember that. That is very important. Most people do the pressure, say it's normal, or you don't have glaucoma. That is totally incorrect. Now, there are certain, sorry. My slides are not moving. Yeah. So IOP is the only modifiable risk factor. And so that is why it is important to measure it, because every therapy that we have available currently is directed towards intraocular pressure. And there is very good evidence from large randomized controlled trials saying that, excuse me, reduction in IOP delays or prevents glaucomatous visual field and disc progression. So one has to be able to document that correctly too. But there is a huge dichotomy in glaucoma, and this might confuse a few people. So let me just clarify it for you. Intraocular pressure may not be raised in open angle glaucoma at all. And we know this subgroup of glaucoma as normal pressure glaucoma. It may also not be high in primary angle closure, especially in the early stages. The disease is intermittent in nature, and therefore you may not, at the time the patient presents to you, detect high pressure. And generally, IOP is always high in primary congenital glaucoma. So in primary situations, it is glaucoma only if the disc is affected, not if, you know, the IOP, doesn't matter what the IOP is doing at that stage. Okay. However, in secondary glaucomas, mere raised IOP is given the nomenclature glaucoma. Disc may not be affected at all in the definitely in the early stages. Therefore, a secondary raised ocular hypertension or secondary ocular hypertension may be a more appropriate terminology, but unfortunately, this is not currently internationally accepted. We still call call any raised IOP in secondary situations as glaucoma. So if we see glaucoma as, being an umbrella, on the one side, you have two, very well-known diseases, primary open-angle glaucoma and primary angle closure glaucoma, which has slight female preponderance, whereas open angle probably has slight male preponderance. But apart from this, on the open angle side, you have other diseases. And it is not enough for you to say patient has glaucoma. You have to find the etiology of glaucoma. And as you can see, there are hundreds of diseases. And I have not even named most of them. This is under the umbrella of optic disc damage. And you may have on the one side open angle, as I was talking about, where gonioscopy is a must to be able to say that it is open angle, versus a closed angle, where gonioscopy becomes even more important. Indentation gonioscopy is the procedure of choice because it tells you whether the angle is appositionally or synically shut. Nonetheless, the question then you may ask is, why do we need to examine the disc? Now, I'm sure it has become very apparent to you that because it's a chronically progressive optic neuropathy, the optic nerve head and the retinal nerve fiber layer is the cornerstone for diagnosis of the disease and also for monitoring progression. Please remember, it can be very difficult to diagnose the disease in the early stage. Quite often, photography and sometimes imaging helps. Imaging does not help in all cases. Please remember that. There is a very wide range of normal discs, physiological range. There currently is no normal level of cup disc ratio. Please remember that. You cannot say it is 0.6 and therefore it is abnormal, and it is 0.5 and therefore it is normal. It does not happen like that. It depends on the size of the disc, and I will show you examples. Please also remember that unusual looking discs do not necessarily make it an abnormal disc. You still have to rule whether or not glaucomatous changes are present. So here are examples of very wide physiological range of normal discs. And here, abnormal discs. Whereas if you look at the cup disc ratio, you'll probably say all these discs are normal. So that is why you need to qualitatively assess the disc. And therefore, the requirements for evaluation are twofold. One is biomicroscopy, because you need stereoscopic view. And no matter what lens you use, you have to apply a corrective factor if you're looking at the size of the disc. So why corrective factors? You will get this in chart in work, but you can see that if you are using a 90 or a 78 diopter lens, then there is a slight minification. So you have to apply a corrective factor of 1.3 with 90 diopter, 1.1 with 78 diopter. It's only 66 diopter, which gives a 1:1, whereas a 60 diopter lens will give you a slight magnification. So the second point, the reason why you need to have biomicroscopy is I will try and demonstrate on a 2D picture of why 3D is important. Look at this disc. We need to find out where the rims, the neuroretinal rim is. We detect that by the bend of the vessel. The bend of the vessel may not be very apparent on a 2D photograph, but if I make it somehow a 3D simulation, you can now easily make out the bend of the vessel, so you can easily find the limit of the rims. So let me go back to that photograph, the disc photograph, and let me mark the bend of the vessels one by one. You will, it may have shifted a little bit, but more or less it is in position. You can see where I'm marking the bend of the vessels. You have to follow these clues, okay? And then I re-emboss that photograph. And if you can now appreciate that where I have placed the points is exactly where the vessels are bending. So that is the limit of the rim from the margin to the bend of the vessel. That is something which is very important. That is why you need biomicroscopy. And the second thing that you need, second very important thing that you need is a systematic approach. You can't just look at a disc and say CDR 0.7. No, you have to resist from doing that. Why do you need a systematic approach? Is because some discs may appear apparently normal, but are actually abnormal. And some discs may appear abnormal, but are actually normal. We'll have a few examples, don't worry. Here we are. The first thing you look for is the size. Then you look at the neuroretinal rim, including its color. Then you assess the nerve fiber layer, retinal nerve fiber layer. Then you look for disc hemorrhages, and then you look for peripapillary atrophy. I just look at these 5 points on a regular basis. And when I have this systematic approach, I hope I don't miss findings. Therefore, to do all these things, biomicroscopy is essential. Where does CD ratio appear in the scheme of things? Not anywhere really. CD ratio is something I talk about the last. I really look at the qualitative features. I don't look so much at the quantitative features. At the end of the day, quantity does not matter so much. So why is size important? Let's take the first point now. Size is important because the size of the cup is linearly associated with the size of the disc. In other words, larger the disc, larger will be its physiological cup. So just because it has a physiological cup of 0.6, 0.7, even 0.8 doesn't mean it's abnormal. Please remember that. So here we have 3 discs. They are of 3 different sizes. You can see, you can compare the size. On the left-hand side, it's a small disc, relatively small disc. Middle of the pictures is a average size disc and a large disc on the right-hand side. You can see that the larger disc has a larger cup, but it's a physiological cup. It is not a pathological cup. However, if I hadn't shown you the comparison and I had only shown you the right-hand side, quite a few of you would have said that is an abnormally cupped disc, would have called it glaucoma. So here, the CD ratio of 0.3, 0.5, and 0.7 are all normal. None of them are abnormal. So how can you say there is a normal CD ratio or an abnormal CD ratio? Why does this happen? Why does a large disc have such a huge cup? See, a large disc has greater surface area, so it accommodates the same number of axons in what looks like lesser space, looks sparser, and it's vice versa for smaller discs. So they appear crowded. We call small discs crowded for a reason. That's because they don't have much space to accommodate the same number of axons of the ganglion cells. Quite often I give an example here, and I keep repeating myself here. You look at the room that you are in. If you were to double the size of the room, the same amount of furniture would look as though it's got a lot of space in it. Whereas if you halve the size of that room and keep the same amount of furniture, that room will start appearing very crowded. Same phenomenon happens with the disc. How do you assess a disc in terms of size? Basically, you read it off the scale. Certain slit lamps are much more useful, certain slit lamps are not. And when you have seen 100, 200, 500 discs, you put your lens onto the eye, you'll be able to say immediately, oh, this looks like an average size disc, this looks like a small size disc, this looks like a large size disc. Remember, when you're doing it in the first few stages, you need to apply correction factor unless you're using a 66 diopter lens. How do you measure the size? Basically, you align your slit beam to the top and the bottom of your disc, a very sharp beam. The beam should be very sharp, and you read it off the scale. A small disc would be less than 1.5 millimeter, and a large disc diameter would be more than 2 millimeter. Anywhere in between is considered an average size disc. Remember, if you ignore disc size, then it is quite likely that you will overdiagnose glaucoma in the large disc, which has a large physiological cup. And this happens very often. Quite a huge chunk of my clinical work is to overturn the diagnosis of glaucoma made elsewhere, just based on a large disc with a large physiological cup. And then you may underdiagnose or misdiagnose glaucoma in eyes with small disc, where even a 0.3 cup or a 0.4 cup may be pretty significant. All right. The next point is the rim, which, as I have alluded to before, is the distance between the border of the disc and position of the blood vessel bending. So here I have marked out for you the border of the disc, followed by the bend of the vessel, okay, bend of the vessel. These are the clear ones for me. And then based on that, I have marked out the neuroretinal rim. So the green area that you see is basically your neuroretinal rim. Immediately, you will see, even in this normal physiologically cupped disc, your pallor cup, meaning the central pale area, is less than the actual cup in that eye. In this eye, it does not matter because it's a normal disc. But unfortunately, the underestimation of a cup that happens when it's only based on the central pallor makes you misdiagnose or miss the diagnosis of glaucoma. How do you trace the blood vessel is also important. It has to be traced from the floor of the disc right up to the rim. Okay, floor of the disc. That's very, very important. So here, my cup is actually greater than the central pallor. This some people call contour cup. I mean, it really doesn't matter. You need to find out the cup, whether it's a pallor cup or a contour cup. It does not matter. But quite often in glaucoma, you will find cup is actually more than the central pallor. Here in this photograph also of the disc, what am I seeing? Central pallor is probably just extending between those two black arrows, thin black arrows. But I know that my rim is actually lost because I am tracing this blood vessel from the floor. It disappears and then reappears. Why does that happen? Basically, it is traversing the steep cup of the steep excavation of the disc. So it appears to have disappeared and reappeared. I will show you the phenomenon in a minute. Again, here, pallor seems only 0.5 or 0.6, but if I look at my contour, bend of the blood vessel, I can see that the blood vessel is bending inferiorly almost at the rim. And the other thing that is helping me with this change is the fact that I can see a nerve fiber layer developing. That nerve fiber layer defect appears darker. It appears as though the texture has been lost, as you can see there. And when it's wider, when it's bigger, it exposes the blood vessels. So the blood vessels start appearing darker as well in comparison to the other pole. So most people teach neuroretinal rim in the form of isn't rule, meaning where inferior is greater than superior, greater than nasal, greater than temporal. In other words, inferior should be thickest, temporal should be thinnest. And people talk about a proportion as well. If temporal is 1, then superior is generally 1.5 times that of temporal, and inferior should be that, or twice that of temporal. So if temporal rim is greater than the vertical poles, then you must suspect glaucoma. And the change in the neuroretinal rim can be both focal and global. Focal loss is called a notch, and it's 3 times more common inferiorly. But what is the problem with this isn't rule? Unfortunately, it is not. Isn't rule isn't valid for almost 40% DIS. So if you just base your assessment on the isn't rule, you may go wrong once again. Notch is accompanied with a visual field defect. We all know that. And this is virtually pathognomonic of glaucoma. It's still not totally diagnostic. What happens is when your rim is lost, then you get this bean potting. Blood vessels seem to disappear and reappear at the margins. Have a look at that phenomenon, what I was talking about. We trace the blood vessels on the floor of the disc. Yes, floor of the disc. When it is traversing the steep excavated wall of the nerve, it is not visible to us because we just look at the face of the optic nerve. We cannot see the insides of the optic nerve. But when the same seems to reappear on the disc margin, it's basically just coming continuous and just onto the retina. So this phenomenon of disappearance and reappearance of a blood vessel or discontinuity of a blood vessel happens because of excavated disc and is due to and causes notching and is almost pathognomonic of glaucoma. Here in this picture, and this is something I found just today, and I was discussing this with my fellow. I see 3-4 blood vessels that disappear and reappear. You can see this one disappears, reappears. This one disappears, reappears. This one disappears, reappears. This one also almost disappears and reappears. So does this one, and so does this one. So what is it telling me? That both superior and inferior the rims are virtually lost. And how do I corroborate that with the nerve fiber layer? You can see there is no pattern at all in the nerve fiber layer. And what else? We see peripapillary atrophy. We have a zone, beta zone, next to the rim, next to the margin, and alpha zone around it. What you see here is not rim. What you see here is very much peripapillary atrophy. This disc has virtually no rim, but most people will call it 0.9. Let's have a look at another disc which has more peripapillary atrophy, but has rim still intact. You can see it's not disappearing. I can see some amount of rim on this left side. Temporally, it is the thickest, but superiorly and inferiorly, it is lost. However, none of the blood vessels are disappearing or reappearing. Yet, you do see a rim of peripapillary atrophy around it. So you can compare the two. Okay, both are glaucometers, no doubt, but the right one is way, way more advanced than the left one. This is the way one needs to look at peripapillary, the rim. To find out the limits of the rim, you have to follow the bend of the vessel. There is no other way to find the rim. Then the next and the most important, in my opinion, is the retinal nerve fiber layer. We all have 1.2 to 1.4 million optic nerve fibers. There is an annual loss of 5,000. So by the time you get to 70 and 80, you do have quite a bit of attrition, but that's age-related attrition. The striations that you see are most prominent in the superior and inferior arcuate regions. And of course, it is much more marked in younger eyes. And after this arcuate fibers, there is a normal transition to a less bright striation in the papillomacular bundle. So have a look at this particular disc, which is completely normal, and try and look at the nerve fiber layer. You can find this pattern. Can you find that pattern? Have a look once again. Look at the striations, look at the texture, look at the pattern. Blood vessels, superior and inferior pole, don't appear darker. So these are the arcuate fibers, superior inferior pole, and this is the, papillomacular bundle. Papillomacular bundle is less bright. That is normal physiology. It is not pathology. Okay. I do have a study where we have seen that both across all decades, it is inferior, which is slightly thicker than superior, although in the later years, later decades, that both superior and inferior come down, but nonetheless, inferior is always thicker than superior, and temporal is the least. We know that. We know that temporal is the least because the temporal margins are the thinnest. What is the relation of the nerve fiber layer to your visual field defect? So if you have an inferior nerve fiber layer defect with an inferior notch or thinning, then you will have a superior arcuate defect. That is the relationship. How do you detect it? The best detection clinically is with red-free filter. So basically your green filter, where you look for dark areas where the texture is lost and where the blood vessels appear darker. Of course, photographs help immensely. We call them red-free, but basically they are black and white photographs. There are three types of RNFL defects. The diffuse loss is the commonest and unfortunately the most difficult to pick up because there is only loss of striations and less texture. Then you have the slit defects and then you have the wedge defects. The wedge defects are the most striking. Let's take the example one by one. Here, if you look at, don't even look at the rim, just look at the nerve fiber layer. I think you can make out that this area looks darker, this area looks darker, and this area looks much lighter. So nasal and temporal nerve fiber layer is intact, but superior and inferior is affected. It appears almost as the blood vessels are naked because the blood vessels, the major blood vessels, run in the nerve fiber layer. So there is no nerve fiber layer, the blood vessels start appearing darker. When compared to the area where nerve fiber layer is present, it also appears as though it's naked, it's been exposed. This is very important to tune your eyes to this. If you look at a red-free, it becomes that much more apparent about the dark areas. Can you see the dark? I hope you can see the dark areas here with no pattern. These are the areas where you should have the maximum pattern, the maximum texture. Here, in this eye now, it is very blurred due to cataract. The photograph is very blurred. The view is also very blurred. But even if I couldn't make out the rims, I could make out that the nerve fiber layer inferior on the right-hand side was the least. Superior was also reduced compared to the normal eye. So, you don't always need to look at the rim to call it a CD ratio. You just need to see and correlate with nerve fiber layer and visual field defects. Of course, she had a very significant superior visual field defect. Then you have the slit defects, which may be normal, and they are then called pseudo slits because they don't extend up to the rim. They have to extend up to the rim for it to be significant. And if they are less than the thickness of the blood vessel beside it, then they are not significant. So let's have a look at a few examples. Here we have, you may look at the disc and you say, oh, what is wrong with this disc? Nothing is wrong with this disc. But look at the nerve fiber layer. I hope you can appreciate this darkening here and this one beginning to occur. And they're all both coming down to the optic disc margin. The corresponding area in the inferior arcuate fibers is completely intact. Now look at the width of that change. That is definitely more than the corresponding blood vessel. And because it's coming up to the disc margin, it is significant. So this is significant slit defect of the RNFL in the presence of very normal looking rims and, if you please, cup disc ratio. So even in 0.2, 0.3, you may have problems with glaucoma. This is the other eye of that same gentleman. This patient had PVD, so it's slightly covering up the inferior area, but you can see, compare it to the inferior one on the other side, there is no pattern, there is no texture. So here nerve fiber layer is lost. And when you compare the superior of the two sides, definitely the left one is looking worse. So this patient has asymmetric glaucoma coming up in the right eye, definite in the left eye. Then what do we mean by pseudo slits? Forget about the very exposed cup here. You can see these slits, multiple, which are actually very thin, don't extend up to the disc margin. These are like corrugations in the RNFL, and these are not significant. Remember, they have to be almost the same width, if not more, than the blood vessel adjacent to it. And the second thing that needs to be there is that it should come up to the disc margin. Here you can see that this slit now has become slightly wider. And when it fans out like that, this is a very thin fan, very slim fan. This is then known as a wedge defect, as you can see here. So you can see that the wedge has increased in this particular eye, but look, there is slit as well superiorly. If we didn't treat this patient at this stage, then this would join up and start becoming a wedge. So you have to be able to pick up these things. See, the rim superiorly looks more or less healthy, not the RNFL. So obviously it will manifest itself in the rim in due course. Then we have definite change in the rim inferiorly, as well as the RNFL change. Becomes so much more prominent when you use red-free photography. Then the wedge defects, like I said, very, very dramatic. Again, very dramatic wedge defect here. But look, again, inferiorly, I'm detecting some change, and I'm detecting one more change, and that is a resolving disc hemorrhage. So if you don't have this systematic analysis, you will not be able to pick up changes that are relevant for diagnosing glaucoma. You will talk about some points which may be non-specific or only mildly suggestive of glaucoma. And I'll give you a list of those as well. Again, here, inferior rim, I've marked the rim for you. Inferior rim is thinned out based on the bend of the vessel, and you can see a fanning out, very marked wedge in this eye as well compared to the superior. Then, same here. This was also a very difficult view, but you really did not need much to discover this, wedge defect between two blood vessels in the inferior pole of this particular eye, even though the rims look more or less healthy. So one has to be very careful about retinal nerve fiber layer defect. One has to be able to pick it up. So disc hemorrhages mostly occur at the inferior pole and is called a disc hemorrhage if it is within 1 disc diameter of the optic nerve. It's flame-shaped because it's in the RNFL, and it occurs more in normal pressure glaucoma. This is the kind of picture you get in a florid disc hemorrhage, but it may not be florid at all. It may be resolving. It takes about 6 weeks to resolve. And generally indicates progressive damage. So it's very important to pick them out. Of course, you need to rule out any retinal vasculopathies, the commonest being diabetic or hypertensive vasculopathy. And of course, it can occur at the superior pole also. But sometimes it just masquerades a blood vessel, and you never ever think that that could be a disc hemorrhage unless you have that in your systematic approach. Look at this one here. Okay, it's not right at the disc margin. It's a little bit away from it. What did I say? It has to be within 1 disc diameter. And if you look at the rims, you would have thought, or if you were just looking at the central pallor, you would have thought this is a normal disc. But look at the bend of the vessel. You can see that this vessel is bending almost at the margin of the disc, and that there is this hemorrhage as well as darkening of the retinal nerve fiber layer compared to the superior. So obviously, this is glaucomatous change. What about this one? Can anyone pick up? It's obviously glaucomatous. The disc, there is no doubt about it that it is glaucomatous. But here again, there is a disc hemorrhage. So to us, it means that the disc or the damage is progressive in nature. And whatever therapy the patient is, you may have to rethink your strategy. Then peripapillary atrophy, we all know the beta zone lies just next to the disc margin and usually temporal in normal eyes. And it is usually present in myopes and sometimes in emmetropes. So beta zone is generally present. Alpha zone is adjacent to the beta zone, and there is variable degree of hypo and hyperpigmentation. Both of these can be non-specific, but they are known to enlarge more in normal pressure glaucoma compared to hypertensive open angle glaucoma, especially the beta zone. Remember, in normal eyes, it does not occur nasally. In normal eyes, it's usually temporal. In myopic eyes, it's usually temporal. You'd call it a temporal crescent. So have a look at this disc. You would have thought, if you didn't know that beta and alpha zone are existing, you would have called it a fairly large disc. But actually, let me mark out the margins for you over here. Actually, the disc is only average size. And there is this beta zone of atrophy, which is also extending nasally. And then there is this variable zone of hyperpigmentation in the alpha zone of pigmentation, peripapillary atrophy. Okay, so I already showed you these two discs before. You can see it is extending nasally. You can see it is extending nasally. How do I know that this is atrophy and not rim? Not only by the bend of the blood vessels, their disappearance and reappearance, but also the fact that when you're using biomicroscopy, this is at the level of the sclera, at the level of the retina. When you have rim, the rim stands proud of the level of the retina. So it is in 3D, you will see it towards you, whereas a beta atrophied area, peripapillary atrophied area will not appear like that. So therefore, I come to this list of what is definite or very suggestive signs of glaucoma. So if there is documented diffuse thinning of the rim or documented concentric enlargement of the cup, documented meaning patient is being followed up and you are documenting that it is increased. In other words, there is progressive change in the disc. Then another very definite sign of glaucoma is an acquired pit of the optic nerve. Not much is talked about it, but I will show you a few examples in the next few slides. The way to detect an acquired pit of the optic nerve versus a congenital pit. Of course, acquired pit will occur much later in life. Congenital pit, by its nomenclature itself, presents much earlier on in life. This is one such case, but because it's a beautiful demonstration of the pit, I'm showing it to you. What did I say? Always trace blood vessels from the floor of the disc. When you trace this blood vessel, that seems to become discontinuous there and somehow seems to reappear here. So the same thing is happening, same phenomenon in a very focal way. What phenomenon? Loss of tissue. So what has happened here? There is a pit here, and that pit has a very definite nerve fiber layer defect. You can see how dark it is in the nerve fiber layer here compared to superior pole. So you follow that blood vessel, you can see it disappears in the pit and then reappears after that, after it comes out of the pit. That's a congenital one. But look at this definite glaucomatous one. Both this look very similar, but they are different. They are teardrop in shape, as you can see. Let's take one disc at a time. I've drawn the margin. I can't find the rim inferiorly, so it is definitely not. Superiorly, I can see that there is some rim present. And when I compare the RNFL, the lower one, the lower pole, the inferior one seems to be affected more than the superior one. What about the other eye? Left eye, here again, fairly similar. You can see that I can't see the lower rim, so it's notched. Superior seems to be present and looks almost like the right eye, but look at the nerve fiber layer. The loss in the nerve fiber layer inferiorly is way more dense and marked compared to the right eye. That's one. And second, you can see slit damages appearing superiorly as well. And there's another difference between the two eyes, and that is in this area. Can you see on the left-hand side, this particular blood vessel, you can trace it fully, right up to the margin. Whereas this blood vessel here seems to disappear and then reappear again on the disc margin. That is a pit. That is a pit here. And when you see it with 3D end on, it is actually pretty apparent, but you have to know that it may be present. That only then can you pick it up. Same here, another one. Follow that blood vessel, it seems to disappear. Somehow not seen anymore, and then seen again at the rim. That also is a pit, acquired pit of the optic nerve head. This is a definite sign of glaucoma. Presence of APON, acquired pit of the optic nerve. Then loss of rim tissue and notching is highly suggestive. NFL loss is highly suggestive. It is not definite. Please remember, you have to correlate. Asymmetry of cup greater than 0.2 because it's present in less than 1% of the population is also highly suggestive. And a vertical extension, meaning we actually only talk about vertical cup. We don't talk about horizontal cup so much. A CD ratio greater than 0.6 is only moderately suggestive, and a nasal extension is only mildly suggestive. But what happens is that we are taught about mostly the vascular signs. What are these signs? Nasal shift of this vessel, laminar dot sign, bearing of circumlinear vessels, of course, disc hemorrhage, parapapillary atrophy, and bayoneting sign. What's the bayoneting sign? Basically, as you know, the bayonet has a double angulation. That is what you may see on when you follow the blood vessel on the floor. The bayonet is the double angulation of the blood vessel there. But what about the performance of these vascular signs for the diagnosis of glaucoma? Nasal shift of this vessel is a non-specific sign. Laminar dot sign is also non-specific. Bearing of circumlinear vessel is mostly non-specific to very mildly suggestive. Then bayoneting sign is moderately suggestive. But by the time you get a bayoneting sign, you have other signs in the disc, like RNFL changes. Then you have parapapillary atrophy. We talked about it. It is moderately suggestive, and disc hemorrhage, highly suggestive. So therefore, parapapillary atrophy and disc hemorrhage have more relevance than the other signs that are taught traditionally about how to find glaucoma. Because there is so much dilemma in the diagnosis of evaluation of a disc for glaucomatous changes, there was a think tank in the late 1990s composed of very eminent glaucoma specialists who were called FORGE, Focusing Ophthalmology on Reframing Glaucoma Evaluation. They came up with 5 R's, and the same 5 R's are the same 5 points I gave you. The first point was observe the scleral ring to identify the limits of the optic disc. So that's a lot of words for one thing, and that is the size. Then identify the size of the rim. In other words, look at the neuroretinal rim. Then examine the retinal nerve fiber layer. Of course, we talked about the retinal fiber layer. Examine the region of parapapillary atrophy. Basically, look at PPA, peripapillary atrophy, and look for retinal and optic disc hemorrhages. That is basically disc hemorrhages. So these are the 5 R's: size, neuroretinal rim, nerve fiber layer, parapapillary atrophy, and disc hemorrhage. If you go about your disc examination in this systematic manner, there is no way you will miss glaucomatous changes. So where does CD ratio come in all this? Well, nowhere. It is a useful tool for communication. It's much easier to say CD ratio 0.6, rather than saying inferior rim is thinned with RNFL defect, I can see disc hemorrhage. All that thing is very elaborate, is very descriptive, but that is what is required. However, when you use CD ratio, it can be quite misleading, as the size of the disc is extremely important. Remaining rim has to be studied rather than the cup that is normally talked about in CD ratio. And as I have shown you, focal defects may indicate glaucoma even when CD ratio is deemed normal. Therefore, my top tip related to disc evaluation is that rule isn't valid for all this, up to 40%, 38% of this. And I just want to show you some examples here. I have drawn out the rims for you in details. These patients basically did not have glaucoma, but were treated for glaucoma for a very long time. Here, rule isn't obeyed, but when you look at the nerve fiber layer, it is completely normal. It's a large disc with a very large physiological cup. Even though rule is not obeyed, it is a normal disc. Same here. Rule not obeyed to a certain extent. There's a slightly tilt in the disc as well. And still, it is a normal disc. Here, rule is obeyed. Inferior is more than superior. There is parapapillary atrophy also, and is extending nasally. That's where bells should start ringing. But look at the nerve fiber layer. Can you see the texture inferiorly where the rim is better? But there is no texture in the nerve fiber layer superiorly. So there is diffuse loss superiorly. So in spite of the fact that we have, and there is a slit coming up inferiorly also, that we have rule obeyed, this is an abnormal disc. Same here. You look at it, you say, oh, this looks normal. The CD ratio is only 0.4. But look at it carefully. What do I find? Where is the RNFL? Can you see that it's darker superiorly? Can you see that there is a disc hemorrhage adjacent to it? It may be disappearing. It may be resolving. Okay. So it may not be that prominent. You have to pick it up. You pick it up only if you have the system in your head. If you don't have that system in your head, you will not pick it up. So it isn't rule obeyed, but this is an abnormal disc. Then it also is very, very difficult in myopes. I have seen most myopes being either having a misdiagnosis, and in myopes, really, if you overdiagnose a little bit, it doesn't matter, but you should not miss the diagnosis because they have other problems and that can affect their vision. So here, I wanted to tell you about this young man, actually. He was a myope and he had pigmentary changes, which of course was not picked up when he first came to me. He was not referred, he came on his own. He was being treated for glaucoma in both eyes, whereas I only saw glaucomatous changes in his left eye. I hope you can see that too. Look at the overexposure of the disc. Please don't worry about it. Just look at the nerve fiber layer. Beautiful texture superiorly and inferiorly, right side, but not so on the left side. You can see what a dark window is present on the left side. Right side, look at the red free, absolutely normal. Left side, look at the red free, you see a beautiful wedge defect of the RNFL. And you can also see, if you trace the blood vessels, you will see that the blood vessels are bending at the margin. Here's another disc, another patient, very high myope. He had clear lens extraction elsewhere. But the ophthalmologist couldn't understand why the patient was complaining about poor quality of vision. So he came to me, and you can see there, it's a very shallow cup, very difficult to appreciate unless you do 3D, but it may be present. Then here's a female. She has JOAG with actually fairly thin cornea. You can see that nerve fiber layer, superior and inferior on the right side and inferior on the left side, is affected. So your rims may not be able to give you much information. If you examine the nerve fiber layer, you get way more information in such patients. I love the disc photograph of this gentleman also. He was also diagnosed as glaucoma in both eyes. He was tilted, very tilted on the right side. And when you are tilted like that, you have to go by the crescent to know exactly which one is the temporal rim. So actually this one is his temporal rim. This is superior, this is inferior, and he has beautiful nerve fiber layer texture. Whereas if you look at the other eye, he has lost, if you can see, the nerve fiber layer is lost inferiorly. Similarly, with so many other cases, you can pick it up just by, not by the CD ratio, but by the nerve fiber layer changes. Here you can see slit defects, superior and inferior on the right side and superior on the left side. I will end with a tale of two young patients. Both were males, both in their late 30s. Both did not have any family history of glaucoma, but both have pressures of 23 and 21. And both have CCT, which was similar. This I picked out from my library. Both have open angles and both have normal visual fields. So let's look at this. This is male 1. You look at his disc, you look at it in greater details. I feel that the rims look fairly okay. So does the nerve fiber layer. I do not pick up any change there in the right or the left eye. Whereas when you look at male 2, and don't worry about the pallor, that is just a photographic artifact, unfortunately. But you see there is hardly any texture. He is the same age as the previous male. So if this disc were to be normal, the texture should be the same as the other gentleman. He has some texture in the left eye superiorly and a little bit inferiorly. But when you compare the right eye of male 1 and male 2 has RNFL defect, both superior and inferior on the right side. Male 2 has mild diffuse change of the RNFL inferiorly of the left eye as well. And it's easily, that much more easily picked up on red-free photographs. Everything that I tell you, such beautiful texture of male 1, not so beautiful texture at all, male 2. So our diagnosis changes. One male has ocular hypertension, the other male has preperimetric primary open angle glaucoma. So this is how specific a diagnosis you need to get based on your disc examination. So disc may have qualitative features suggestive. Do not rely on CDR alone. And contrary to whatever popular belief there might have been, there is no normal level of CD ratio. Anything above 0.6 and above may be suggestive, but disc size is important. So I end with some key points. Evaluating a disc based entirely on CD ratio is inappropriate. Concentration on central pallor for this purpose usually leads to under or overdiagnosis of the damage, underdiagnosis of the damage, sorry. There is no normal level of CD ratio, large disc, will have large cups, but you still have to prove or disprove whether glaucomatous features are present or not. It is the bend of the vessel which defines the limit of the rim, and therefore your biomicroscopy is extremely important. Then, rule isn't valid for all discs. Presence of rim thinning and RNFL defect is a highly suggestive sign of glaucoma. Remember, unusual appearance of the disc does not make it abnormal. You have to prove or disprove glaucomatous features. If possible, I would always encourage you to photograph the disc. It gives you that much more insight into glaucoma diagnosis or its exclusion. Always remember, non-glaucomatous causes must always be excluded. So disc examination is fundamental in glaucoma. You cannot call it glaucoma if you have not examined the disc and diagnose changes. Clinical correlation of OCT and HVF. OCT again is a structural thing. HVF is functional. But whatever tests you do, you have to correlate clinically. This is mandatory in glaucoma. Thank you very much for a patient listening. Are there any questions? I'll be happy to answer.
Thank you. Thank
What a
you.
mesmerizing lecture, madam.
Absorbing.
Vanitha, I expected you to involve the PGs in some of the disc photographs.
I know, but I somehow don't know them, and it just increases the time. So I'd rather they talk to me now and clarify their doubts.
Now you can ask questions also showing these pictures.
You can ask them. Maybe you can go to the discs of some of the slides and then
Yeah,
let them
sure.
answer.
But now I have given them the answers.
Doesn't matter. They may not be remembering everything.
That will be a test of their recalls.
You can know how much they have remembered.
Hello, good evening. Can you hear me?
I did keep this separately, and then I took them off simply because I thought that it would completely mess up the time. Okay, here we are. Who would like to answer? Who would like to describe that disc?
Can call someone's name.
I can't see them at all. That's why it's difficult for me to.
Richa.
I would like a volunteer, please.
Dr.
Come
Richa
on.
is there. Richa Gupta.
She's a consultant.
Yeah, she's there, I think. Yeah.
So, but the voice is not.
You are not audible. Yeah, you are. Dr. Sangeeta.
Good evening, sir. Good evening, ma'am. Can I
Hi.
volunteer?
Please, please.
Yeah.
Yes, ma'am. The disc appears normal, but the cup is enlarged because we can see
Hello. This appears normal. Is that how you start? What did I say? 5 points.
Sides.
the size of the disc. First
Okay.
one.
So if you get only one disc, obviously you can't talk about the size. Yeah,
Yes,
because you have no comparison. So you can always say, I cannot compare it. I cannot be sure about the size. So at least the examiner will know that you have that in your head. Then the second point.
Ma'am, the NNR, looks there is thinning.
NRR, yeah, neuroretinal
Retinal
rim.
rim.
NRR, yeah,
Yes, ma'am.
yeah.
The NNR, the NRR looks thinning in the superiorly. Superiorly, there is thinning.
Is it superior?
Yeah.
Next.
And the inferior is more thinning than superior.
Look at the bend of the blood vessel. Where is this
Yes, ma'am.
blood vessel bending? It's almost at the margin, isn't it?
Margin. Yes, ma'am.
Whereas here it is bending there, there, there. So there is still some rim there.
Yes, ma'am.
Then how do you say superior is thinned rather than inferior?
Ma'am, inferior is more thin than superior.
Okay, we don't know about that. Superior looks healthy, but inferior is definitely thinned. What about the RNFL?
Are you seeing
Any change in the retinal nerve fiber layer? My whole
inferior,
talk was
superior?
about retinal nerve fiber layer.
Mhm.
You know, nowadays I don't look here. I look here and here. I don't even look at the disc.
Do you find any abnormalities inferiorly or superiorly?
What is this? What is this area?
Yeah.
Hello.
Let her locate Vanita, because you said they will answer now, which will not happen. Dr. Vibha,
Yes, sir.
can you see any nerve fiber layer defects in this picture?
Yes, sir. Inferiorly, it is. There is retinal nerve fiber layer defect.
What is the
Where exactly?
Ma'am,
Say in clock hours. This is the left eye.
Yeah.
So if that is 12 and this is 6, where do you see it?
ma'am, around 5 to 6.
Very good. Very good. That's your wedge defect. Can you see it's darker than the rest of the nerve fiber layer? What are you seeing?
And
Anything
are they seeing
superiorly?
anything superiorly? Yes. Vibha, Dr.
Yes.
Vibha.
No, sir.
Look at it
No.
carefully.
I can see.
Very carefully, it's very wide in inferiorly, but superiorly, are there any nerve fiber layer defects?
Can you see there's something slightly darker? These two
These two.
coming down to the disc margin.
Yes, ma'am.
Huh? So these two
wider than the
also,
vessels, wider than the vessels. That's why
yes.
Thicker than the vessels.
Yeah. So what are they?
Slit shaped defect.
Yeah, slit defects, slit RNFL defects. So actually she was not incorrect when she said the superior rim is affected. It's very difficult to say superior rim looks healthy, but nerve fiber layer suggests that superior rim is not healthy. Whereas definitely inferior rim is thinned out, almost notched with this nerve fiber layer defect. Okay. And the pallor looks only this much, maybe 0.6, but actually the cup extends from there to there. Okay, so CD ratio is way more than what the central pallor is suggesting. Therefore, one should always be mindful of the contour cup. Don't go for the central pallor. Everyone looks at the central pallor and first thing they say it is HNRR. Healthy neuroretinal rim. If you're saying healthy neuroretinal rim, then what is this? This is abnormal, isn't it? It's not healthy. RNFL is lost. How can that be healthy? That is glaucomatous. Okay, let me find. So when you look at the nerve red-free photograph, it becomes so much more clear. Can you see? So much darker. Sorry, who was the resident who said first?
Yes, ma'am. Hello.
What's your name? Sorry.
Sir, ma'am, myself, Pratibha Behra.
Pratibha.
Yes, ma'am.
Can you now appreciate what I'm talking about?
Yes, ma'am.
Can you see this dark area?
Yes, ma'am. There is a wedge-shaped defect, ma'am.
Yes, and there is two slits superior. Yeah.
Yes,
so you first started by saying this is a normal disc. You remember?
Yes,
you
ma'am.
should not. You cannot jump into a diagnosis of normal or abnormal unless you've ruled out those 5 points that we have talked about.
Yes.
You talk about the 5 points systematically, immediately you will get the diagnosis. Is it normal or abnormal? Do you get my point?
Yes, ma'am.
Okay, let's see this one. tell me about this one. Who would like to tell me about this one? Someone else?
Yeah, your
Niharika,
arrows are
are you there?
automatically playing, I think. Vanita.
They are actually. To save time, I do all that.
Let them answer, no problem.
Amit can speak.
What are you seeing? Are you there, Amit?
Unmute.
Pradyumna,
Hello.
you're there?
Yes, ma'am.
Hello.
Good evening, sir.
Yes.
Good evening, ma'am.
That's you, Amit?
No, ma'am. I'm Pradyumna from.
Yes, ma'am.
Yeah, Pradyumna.
Pradyumna.
Yeah.
Okay, okay. Fine. Can you describe what you see in this disc?
Ma'am, the size of the disc could not be commented upon.
Yes,
Ma'am,
good.
there's ma'am thinning of the neuroretinal rim inferiorly.
Okay, how did you make that out?
Ma'am, here
You make that out with the bend of the
bend
vessel.
of the
Yeah?
blood vessels by
Yes.
tracing it from the floor of the cup metal.
Yes, floor of the disc, not floor
Yes.
of the cup.
Okay.
Ah.
And ma'am, there's between ma'am 6 to 5 o'clock hours, ma'am, there's a wedge shaped defect of the neuroretinal nerve fiber layer, ma'am.
Yeah, exactly. Very good. So do you think this disc is normal or abnormal?
Ma'am, disc is abnormal because of this ma'am thinning and nerve fiber layer defect.
Exactly. So this is very suggestive of glaucoma. Yeah.
Yes.
Very good. Very good. So this is
Pradyumna, where do you expect the field defect to be?
So superiorly.
Superior where? Superior is half.
Sir, supero-nasal, sir.
yeah, either superinasal or you can get it in the arcuate region also. But that is probably very minor loss still before you start getting the changes. Anyway, that's beside the point. Who would like to talk about this one? Niharika, are you there?
Niharika.
Yes. Good evening, ma'am.
Yeah, hi. What do you see?
Ma'am, here there is a peripapillary atrophy, ma'am.
Okay, don't start with peripapillary atrophy. What did I say?
I
Write
can't
those
read.
5 points onto a paper and
Okay.
start with the first point, go to the last point. Okay. So you talk about the size.
I can't comment on the size of
Yes,
the ma'am.
good, good, yes.
Coming to the euroretinal rim.
Yeah.
So there is inferiorly, it is the NRR appears thin, ma'am.
How do you say that?
Because there is bending of
When the
vessel.
vessel is here, it does not appear thin at all.
Yes.
Okay.
And yeah, there seems to be fairly good color, fairly good rim. Actually, this is a small disc. That's
Okay.
why it's appearing so crowded.
Okay.
Okay, so what about the nerve fiber layer? What do you see, superior and inferior?
Inferiorly, from at 7 o'clock position, I find I find there is a nerve fiber layer defect. There is
here
relatively at 7 o'clock, ma'am.
Here.
No.
6 to 7.
6 to 7 is beautiful texture.
Beautiful, yes. Texture.
Beautiful texture.
There is somewhere it is there. Can you identify which clock hour it is there? Nerve fiber layer defect is there in this picture.
Superiorly, it is there around 11 to 12 o'clock hours.
Yes,
Split,
yes.
split shape.
It is Vibha who answered it.
Yeah. Actually, it's not that apparent. It's not turned out that clearly, but this is a hemorrhage overlying blood vessel. Yeah, I didn't talk about that because it's not clear at all. But we did talk about the slit. So if there is a slit, There is a chance you will detect a hemorrhage there. So now,
how do you detect, Dr. Vibha? It is very not very distinct. So how do you detect in this case?
So first there is a mild.
Dr. Vanita has told some other filter you need to use, which
Red-free filter.
yeah, your green colored filter. And also, not just that, when you see with the biomicroscopy, you look at its pattern. Because it's in the nerve fiber layer, it is flame shaped. It's not the typical dot and blot that you get in vasculopathies. Yeah? Hello?
Yes.
Yeah?
Yeah. She said this.
Yes, okay. So is this disc normal or abnormal?
Abnormal one.
See, now it's so easy to say. You go systematically. You go through the 5 points. Okay, I get the idea about the size, because we can't talk about size when we are seeing only one disc. But if you mention it, then at least we know that you have thought about it. Okay. This size is small. I have magnified it quite a bit, and that is why it's such a crowded disc. So
Dr.
this is.
Pradyumna want to ask something.
Yes, please go ahead.
Ma'am, is there any hemorrhage inferiorly?
Here?
Inferiorly, ma'am.
Here?
Yes, ma'am. That.
No.
That's just that's just a photographic artifact.
Okay.
This is actually.
Hello, ma'am.
Yeah.
Ma'am, what is the cause of the disc hemorrhage in glaucoma?
Nobody knows why it happens, but basically it signifies progression in glaucoma.
Okay.
We still don't know why it happens. We still don't know why it's the superior and inferior. Definitely, we know that the axons, the supporting structures, the Muller cells, and all that, are more susceptible to damage. But why exactly superior and inferior is still not that clear. Okay, so we know there are many things about glaucoma which are still an enigma, a mystery, but we know it happens.
Ma'am, what is the greenish thing which is seen on the fundus image, ma'am?
Partly it is photographic artifact, but this is peripapillary atrophy.
Okay.
Yes, your alpha zone slightly more prominent.
Okay.
Okay, let's go to another.
Good evening, ma'am.
Yes.
Ma'am.
Yeah.
Ma'am, at 5 o'clock, we can see in the left picture, there is bending of blood vessel, and there is obscuration of blood vessel beside that. So, is it confusing when suggestive of inferior thing?
5 o'clock or 7 o'clock? Where are you talking? Here.
Ma'am, 5 o'clock, there is one bent blood vessel, inferior.
Here.
Beside that, ma'am, the thin blood vessel.
That is 6 to 7 o'clock.
Yes, ma'am.
Yeah, so it tells you that the cup is a little bit more than what you're seeing as the central pallor. Okay, that's all that it's telling you. That is definitely the bend. You're quite right. Okay. We can't make definite, in this 2D photograph, we cannot make out definite bends superiorly, but definite, some inferior you can make out. Yeah. It's a crowded disc. There's no doubt about that. It's a small disc and a crowded disc. But if you just look at it on a, just cursorily look at it, you will say, oh, CD ratio 0.3 normal, won't you? Until you go through your systematic examination, you find it difficult to say whether a disc is normal or not. Restrain yourself from blurting out without talking about the features. starting with saying that this is normal, because you may then find that it's not normal. Okay. And second, you also talk about, if you want to say the CD ratio, no problem. You talk about it last. You give me qualitative features, then you talk about quantitative features. Another point, so much is talked about bearing of circumlinear vessels, bayoneting, nasalization, laminar dot sign. None of it is present in this disc. Yeah?
Yes, ma'am.
So does that mean this disc is normal?
No.
No. Therefore, what I say is the 5 points I've given you are like the hard, the hard disk of a computer, without which the computer won't run. The diagnosis won't happen. The other are softwares, soft science. Okay? May or may not happen. But it is not something you have to look for it. What you need to look for are definitely these 5 points. Okay?
Yes.
Ma'am?
Yeah.
Hello, ma'am.
Yeah.
Ma'am, can we say that can we say in this image that the neuroretinal rim appears healthy? Can we say that in this photograph?
Yeah, you can always use the word relatively healthy.
Relatively healthy.
Relatively healthy, because at the end of the day you are seeing nerve fiber layer defect, and based on that nerve fiber layer defect, I will call it likely glaucomatous. So you cannot say 100% glaucoma. Even nerve fiber layer defects can happen in other diseases. Remember that.
Yes.
Okay.
Okay. Thank you.
Yeah. Who would like to describe this disc? Aishwarya, are you there?
Yes, ma'am.
Okay.
Ma'am,
sorry.
So,
yeah.
Ma'am, first of all, the size I cannot comment upon because it is one disc I can see.
Sure.
Second thing, ma'am, superiorly, there is disappearance of blood vessel. It is getting disappeared and then it is coming. So
reappearance. Where? At
yes,
what point?
Yes,
at what clock hour?
At 12 o'clock, ma'am.
Yes.
So the superior neuroretinal rim is thin.
Is thin? Almost lost.
Almost lost, yes.
Yes, because there is nothing there to support that blood vessel. Yeah, to support that blood vessel at the margin. Yeah. What else? The nerve fiber layer is not that easily visible in this because it's a very magnified view. Okay. But still you can see some texture inferiorly. You don't see any superiorly. And I see something else. What is this?
Peripapillary atrophy.
Yes. Exactly. So, what is your diagnosis? Is this normal? Is this abnormal?
No, ma'am. This is an abnormal disc.
Exactly. So once you look at all the features, you can easily come up to the diagnosis yourself. I would like someone to talk about the right-hand side disc. Divya, are you there? There are two Divyas, Sai Divya and Divya. Are you there? No?
No.
Don't want to. Dr. Ranjan?
Ranjan is a moderator.
Ranjan Sharma.
Good evening, ma'am.
Yeah.
Ranjan Sharma is from Warangal.
Yeah.
I'm looking at the list because I don't know them by face.
I know. And most of them are off the videos actually.
Yeah.
They should be on the videos.
Hello.
Yeah.
Hello.
Good evening, ma'am.
Yes. Good evening. You are?
I'm Ranjan Sharma.
Ranjan Sharma.
Yeah.
Okay. Please describe the right-hand side disc.
Right hand side, ma'am. Ma'am, neuroretinal rim is normal.
Hello. You have got 3 discs to compare the size. So talk
Yes,
about
ma'am.
the size first.
Ma'am, first left. First one is smaller disc, ma'am. This
No,
gradually it is increasing.
I'm not
Ask
talking
only
about
about
this.
the right one.
Right one. Answer
Say
to the
compared
point.
to other discs, it is.
Large. Yeah?
Yes.
I don't want to complete that.
Disc is larger, ma'am, comparatively.
Yeah.
And vessels are somewhat nasalization is there, ma'am. Vessels origin.
Okay.
Then, ma'am, neuro cup is cup and disc ratio is more, ma'am, compared to others, ma'am.
Okay. Were these the 5 points I talked about?
Ma'am, sorry, ma'am, I couldn't attend the class, ma'am. Actually, just now I joined, ma'am.
Oh dear. Okay. The 5 points that we talk about when we look at
Yeah,
a disc.
let someone tell. Let someone tell.
Okay.
Dr. Vibha, can
Yes.
you enumerate all the 5 points what she was telling to evaluate when you see the disc? What are those 5 points, 5 headings you will look at it?
First is size of the disc, then neuroretinal rim, then retinal nerve fiber layer defects, then peripapillary atrophy, and then hemorrhages.
Exactly. Very good. Very good.
Excellent.
And lastly, you can talk about CD ratio, no doubt. And once you have described the disc on the points, you can then decide whether this is a normal disc or an abnormal disc. Would you like to describe the disc as well?
Yes, ma'am. If we, when on comparing the sizes of the disc appears to be larger in size with healthy neuroretinal rim, following the ISNT rule, with no peripapillary atrophy and no apparent retinal nerve fiber layer defect and no hemorrhages.
Very good. But how are you saying it's following ISNT rule? I don't think it is. I think superior is equal to inferior.
Inferior here, yeah. The nerve fiber layer also, it's very difficult to comment about in this picture.
Yes.
While facing the examination, you should always be very observant. If it is too magnified, it's better to say that I cannot comment.
Cannot see. Yeah, exactly.
That will score you high. Actually, the examiner will think that yes, they are mindful about the pictures which they are reading.
Look at this disc and the nerve fiber layer. You can see the nerve fiber layer very clearly. Yeah. But here, it's not that clear. So, better to say, and I cannot be very sure because it looks to be very magnified. The photograph appears to be very magnified. But very good, very well done. So, let's look at this disc. Who would like to talk about that?
Prativa is there. Prativa?
Hello, sir. Ma'am.
Hi.
Talk about the disc.
Okay, let me tell you that this is a large disc. Now you talk about the disc.
Ma'am, there is a bending of vessels which disappear and appear superiorly.
Where?
12 o'clock, 11 to 12 o'clock.
11 to 12 o'clock.
Yes. The bending is
you can't see the blood vessel at all. Okay, that is probably a branch. Remember, the disappearance and the reappearance happens when the rim is absent. Does the rim appear absent here?
No, the rim is present.
Be very careful how you describe. Okay. So when you look at the bend of the vessels, superior looks more than
inferior.
Inferior, isn't it?
Yes.
Is it following the ISNT rule?
No, ma'am.
So then it is up to you to now decide whether this is normal or abnormal. How will you do that? Look for the other features.
Ma'am, for the RNFL, then we will look for the.
Good. What do you think about the RNFL? Although it is a very magnified view, you can see the RNFL very clearly.
Ma'am, the RNFL looks normal.
Exactly. Very good. Any hemorrhages?
No, ma'am. I cannot find
No
any hemorrhages there. Yes, ma'am.
Yes, very good. Let me tell you the story behind this disc. This gentleman was diagnosed with glaucoma in 1997, I think, at a time when there were no prostaglandin analogs available in our country. I was not practicing in this country at that time anyway, but he didn't come to me then. He came to me 12 years later when I was in this country. He told me, I asked him why he had come. He said, I have glaucoma and I just want a normal checkup. So when I checked him up and I looked at his disc, I said, you don't have glaucoma. He wouldn't believe me. He was made to import prostaglandin analogs into this country to apply to his eyes when he did not have documented IOP, he did not have documented gonioscopy, he certainly did not have documented disc, and he did not have documented OCT, he did not have documented visual field. Nothing. Zero. Based just on the disc appearance, which is a large disc with a large physiological cup, for 12 years, he went around importing prostaglandin analogs with a tag of a disease which is blinding. And when I told him, he almost fell off the chair. To this day, he does not have glaucoma. You see, you roll it out then, doesn't mean that in future you may not get. But he did not have 12 years, he went around with a diagnosis of glaucoma. So every disc I have, photograph, I have a story behind it. So that is why it is so important. Why did that happen? Is because we do not want to update ourselves. We do not want to gain knowledge. We want to stick to our past, 1980s, 1990s. Concepts change. Diagnosis, how to diagnose a disease changes. We have to upgrade ourselves. We have to continue medical education. Very important. Very, very important. It wouldn't have happened. If I had been that patient, I would have sued that doctor. It's another matter that in our country, patients still revere doctors. Even if a doctor has done them some harm, they will not turn around and go back to that doctor. But they will not do anything severe. Had this been in the West, he would have been sued. That doctor would have been sued. So you have to be careful. We are entering that kind of era now in India. The awareness is growing. It's still fairly minimal, but it's growing. So by the time you get to our age, maybe, you never know. So you got to be careful. You need to know how to diagnose glaucoma. Glaucoma is an enigma. In the early stages, it is difficult. But please remember that if you have done things correctly, there is no one who can turn around and point a finger at you. Glaucoma is progressive in nature. Today, if the pressure is normal and the disc is a suspicious disc, you can, and your investigations look and come back normal. You can wait, you can observe, you can call the patient back, but that has to be documented. You cannot just say verbally, come back, and that's it.
So, can we have comments from the our panelists and the moderator? So it's over to moderator, Dr. Pranav Ji.
Yeah, it was
Sir.
it was a fabulous discussion on disc and disc evaluation. I mean, the 5 points which Dr. Vanita mentioned, and everybody should, even the senior.
You are not audible, sir.
You have to come closer to the mic.
What's it? Can you hear me, sir?
Yes, yes.
Yeah,
yes.
yeah. Now
Better,
it's-
better.
It was a very exhaustive and very absorbing discussion by Dr. Vanita Madam, and I think everybody, not only the residents but also the senior people, should follow the 5 steps to evaluate the disc. This is very, very important. And in between, I would also like to mention that when the disease is of the ganglion cell, so can we have some kind of a mechanism in future by which we can really count the number of ganglion cells, just like a specular microscopy? We have a count of the endothelial cells, so the imaging system can improve later on, so that we can actually count upon the ganglion cell, because they are the real culprits basically. And by comparing the loss of the ganglion cells over a period of time, we can really diagnose glaucoma, because these are all, in fact, indirect evidence. I mean, disc is one of the most important thing. And just one second, because once I was asked, if you do not have anything, just you have a ophthalmoscope, can you diagnose a glaucoma? I said yes. This is the only important thing. Disc evaluation, if you do it nicely, you can, in all probability, not diagnose, but you can get a direction as if the patient has a glaucoma or not. So it becomes so relevant and important. And what you explained is really good, very nice.
Thank you.
Danta?
Yeah, it was wonderful talk by Dr. Vanita ma'am, and quite informative, very lucid, and nothing can be better than this. So nicely taught, not to the residents only, but to us also. And we learned many things. And ma'am, it was very nicely elaborated that the 5 important points, all resident, not only all residents, but all clinicians should keep in their mind these 5 points, so that they will not be able to miss the diagnosis of glaucoma. Thank you very much, ma'am. I just wanted to know the pathogenesis of disc hemorrhage. You told that the cause is not known, but why there is leak from the blood vessel, I would like to know. Then second thing is something I will like to hear, ma'am, from about relation with corneal thickness, because that should also be clear to the residents.
Corneal thickness will not come here, because the IOB
Okay,
measurements
okay.
and relation.
We are confined
That's
to disc.
a totally different topic
Okay,
altogether.
okay. And
Yeah.
glaucoma is yeah.
Sorry, please go ahead.
Yeah. Ma'am, glaucoma is very important now, because this is the second important cause of blindness. And
I like to put it like this. I'm sorry to
Yes.
interrupt. It is
Yeah,
the
yeah.
first most common cause for irreversible blindness.
Yeah.
So that we do not relegate the importance. I think, I feel so sad and despondent that there are certain patients who go to doctors for, we don't have a network of optometrists. So they do go to, who we would describe as primary care doctors, and get glasses done, and they have glaucoma, and they have advanced glaucoma, and these were not picked up. They have been going for 5 years, 10 years, 15 years.
Yeah.
So this is what I feel, that we are to blame. We should be aware. Our brethren, our co-ophthalmologists, we need to increase awareness in them also. There is no doubt about that. No doubt. This concept of IOP being normal and therefore no glaucoma has been discarded 40 years ago. 40, not even recent. So that is important. Second, of course, I don't see anyone other than glaucoma specialists, and even then quite a few don't pick up a gonioscope, whereas any patient that comes in my OPD gets a gonioscopy. It is, it is so quick, so fast when you're used to it, that it is better to see and exclude rather than not do and be in doubt. So I believe, and I do quite, for all my patients. Mind you, my practice is, I would say, 98-99% glaucoma. These are things that, we have to update ourselves. It is a clinical skill. Just as you know how to do indirect ophthalmoscopy, you need to know how to do a gonioscopy. It's as simple as that. It's not that it has to be the preserve of a glaucoma specialist.
That is the next class, Vanita. That is the next class.
Yes.
I already fixed the speaker also.
Good.
Dr. Sharmistha, do you want to have any opinion? Your comments?
Sir, that was a lot of learning for me, sir. I thank you all, and lots of thanks to ma'am too. Those 5 points are really very useful in detecting glaucoma.
Yep.
Dr. Richa is there? Dr. Richa, are you there?
I'm going to add.
Hello, sir, can you hear me? I don't know, there was a lot of...
we are hearing you.
Okay, great, that's great. I try to, unmute and talk in between, but anyway, ma'am, it's always a pleasure to listen to you. I had a couple of questions. Since you talked about the disc size, and I agree completely that it really matters actually in evaluating or examining a disc. So do you go for DDLS? Do you follow DDLS?
I find DDLS very cumbersome.
Okay.
So
right.
I am a very, what will I say, a person who likes to simplify things. And no disrespect to Dr. Spaeth, who's discovered DDLS, who's talked about it. But I like to be, very clean, no fat type of down to these brass tacks. So that's why I do not. I like what Forge did to glaucoma evaluation, disc evaluation. These think tanks are great names in world glaucoma right now, and they did a great job in reframing glaucoma evaluation. Hats off to them. I feel that it's been very, very useful, and because the terminology they use is a little bit cumbersome. They say 5 R's, but it's a mouthful how they talk. So I bring it down. I make it even simpler. So I like to keep one name or one phrase. That's it. So that's why I say talk about size, retinal rim, no fiber layer, parapapillary atrophy, and hemorrhage. That's it. No, look at the limits of the rim and look at the examine this. Look out for region of parapapillary atrophy. All that is very cumbersome. But when you simplify it, when you bone it down, you all are very fond of fish. When you write down to the bone, it's only these 5 points.
So I think the main points in DDLS also is the size, the NRR, and the nerve fiber layer defect, which you already have mentioned that these things, if you look at it, you don't need to follow a score.
Yeah, that's it. There is no other way to evaluate a disc, but the way it is evaluated in terms of numbers, okay, that makes it a little bit cumbersome.
Right, ma'am. And another question which I had was, if you see a trance in a fresh patient, when do you call the patient again for a follow-up, and what would you like to investigate him the next time he's coming to you?
If I am only seeing a disc hemorrhage without any rim changes, without any nerve fiber layer changes, I would first think of whether the patient is a diabetic or a hypertensive or has some such problems. I wouldn't actually jump to the diagnosis of glaucoma, especially when the pressure is also normal. I wouldn't do glaucoma investigations. I would first say, get your BP done, get your sugar done, if you've never had it done. If all that is excluded, then I would call the patient back in, say, maybe 3-4 months. Do a baseline visual field and then repeat a visual fields in 3-4 months. Because at the end of the day, it's meant to signify progression in glaucoma. But a solitary disc hemorrhage may not signify anything in the absence of rim or nerve fiber layer changes.
Right, ma'am. And yeah, that's all. Thank you so much. Thank you for your talk.
BNR.
Sangeeta, are you there? No. Okay. So I think with this we will close the webinar, today's webinar.
Conclusion.
Yeah, may I request Dr. Sabiraj Patel to give the vote of thanks. Before that, Ms. Jyoti, can you share the video of our host today?
Yes, I'll do it.
Yeah.
And 25th October is gonioscopy.
Yeah.
I will not let the speaker's name out.
Why is that?
Can I take this privilege? 22.
Privilege too, sir.
So invite all of you to the EIZOC.
To invite you all.
35th conference at Patna, sir.
Okay.
It will be a, I mean, most
sound is missing. Jyoti, there's no sound.
So that is why we are allowed to talk, sir.
Sir, I'll reshare it, sir.
That is why you
no sound.
the invitation, sir. I'd like to see all of you at the 35th EIZOC conference at Patna, 15th and 16th of this month, sir. That is just 4 days from today.
No audio. Jyoti.
Audio is coming.
Yeah. Audio is missing.
So we have seen the content now.
Yeah.
So thank you very much. At the end, I must thank Dr. Vinita Rao for an excellent presentation on glaucoma. And am I audible?
Yeah, you are audible.
Yes.
Much audible.
Carry on.
Regarding glaucoma, is not against, but there is a lot of confusion in glaucoma consultant also. So they should have a standardized protocol to put it. Otherwise, this confusion there always happens that once diagnosed by somebody, then again refuted by other. So this is how to be done by the Glaucoma Society to find out common criteria to be used by all. Something like a national protocol or some type of thing, so that we will avoid. And the second thing is we are all more concerned about early detection of glaucoma. Because by doing that, mostly we lose patients who have advanced glaucoma and ultimately they are losing vision. So anyhow, we have excellent discussion today. Thank you, madam, very much. It is always our pleasure to have you with us regularly, and also we'll request you to be with us in future also. I must thank Dr. Ajit Babu, our mentor, for taking interest and sincerely trying to develop our residents. So that's why he again insisted that there should have direct interaction with the residents. Now I think that also helped, because after we asked them questions with pictures, then we could know that how much they have understood and what was the lacuna that was there, and it was corrected. So this is the purpose of this ORTS, is the handholding type of teaching to all the residents, mostly those who are interested. If on repeated asking also you will not volunteer to say, because this is the opportunity, it is not exam. by making mistakes also, you are going to learn many things. So if you not volunteer yourself, I think you are losing a great opportunity to learn. So I must thank Dr. Pranab Ranjan, our Vice President of EIZOC, for being with us in the entire session in spite of organizing the EIZOC conference within next 3-4 days. And Dr. Rumta also taking so much of interest and being present with us. My special thanks to Professor BNR Subudhi, our chief code, who is consistently and conducting this program. Thank you all the residents. Again, I request all of you to take interest. These facilities were not there in our time. So even if we are interested to learn, there was no teacher or there was no scope of this thing available at that time. So you should take the advantage of it. And we want the Eastern Indian or the EIZOC states should excel in future in national and international forum. Thank you very much. Thank you, sir.
Can I just make a point against what he just said? The point I was trying to make is, with glaucoma, one size does not fit all, and therefore making a protocol is extremely difficult. And that is why there is so much difference of, there can be so much difference of opinion. In the early stages, diagnosing glaucoma is very, very difficult in the scenario of normal pressure. I will, rest my case there.
Because of this viewing thing that you highlighted on that, because there are so much of things, it's very difficult to, again.
No, one simple exercise the postgraduates do is they can take the disc photographs now on, get it enlarged, evaluate, and discuss with your seniors or even glaucoma specialists who are around you. That's how you can improve your skills.
Every unit has a fundus camera. Every
that's
unit.
why I'm suggesting that.
So take a photo. This is what I said. Take a photo.
Easiest. A bit of taking photographs. Thank you, madam. Thank you very much.
Okay, thank you, everybody. I think it's a good discussion, and I think residents have learned a lot today, and we'll continue for the next webinars. So, thank you all. Good night.
Good night.
Thank you, Dr.
Good night.
Thank you, sir.
Everybody.
Good night.
Thank you.
Nita, thank you very much for obliging.
My pleasure.